The plan here is to go through the presentation, which takes about 30 minutes. And then when we're done with the presentation part of it, we'll take about a 5 or 10-minute break to let everyone just kind of stretch your legs, and we'll come back and we'll start tackling some of the questions. So I'm going to blast through this without stopping to answer questions, just so we can get a train of thought, because a lot of the questions that are asked earlier are actually answered later in the presentation. How this whole presentation came into being: no one approached me and asked, hey, could you do a bunch of webinars for me? It was actually, it was born out of frustration that I had about the volume of information that was flying toward me all at once. Several weeks ago, I just started to assimilate all this information and put it in one place, and then that just morphed into a PowerPoint. Because I figured if I was frustrated and I didn't have my arms around all the information that was flying at me, I figured other people were in the same shoe. So that's where this came from. And so my whole goal here today is to educate from what I know. I will tell you that, as Chief Clark said, that he would be happy to send you this presentation because this presentation is not an endpoint. It's a living and breathing thing. I've adapted and adjusted this presentation as recently as just an hour ago because the information becomes even more current. I want to say right up front that the sources of my information are places that I trust. They are New England Journal of Medicine, Journal of the American Medical Association, my college, which is the American College of Emergency Physicians. I'm an ER doc, for those of you guys who don't know me. I'm an ER doc at Kaiser South, and I've been the Fire Service Medical Director here in Sacramento County for just over 10 years. So those are some of the sources I rely on. I also rely on the CDC, the World Health Organization, so large organizations. And then just because of my involvement in the fire service as many years as I have some considerably close friends who are bright, and I go to them when I need information. So what you're going to see before you in just a few minutes will be an assimilation of all of that. I will tell you that the last two of these has run about 43 minutes or so. So we are going to stick pretty close to that. 43 to 45 minutes. We'll take a short break. We'll come back. We'll answer questions. And the longest this has gone has been an hour and a half. I hope that you find it valuable. And please ask questions, because if I know it, I'll answer it. But if I don't know the answer, I'll just flat out tell you I don't know it. Okay, so I'm going to start a screen share here. This is a little bit of a background. We'll start with some history and some background, and we'll move into it pretty quickly. So, as I mentioned earlier just a second ago, there's going to be a fair amount of scientific material in here. You don't need to be a scientist. You don't need to be a physician. You don't even need to be a paramedic or EMT to understand this stuff. You just have to have enough openness to try to understand it. And I'm going to do my best to explain what I know. So a little bit of background about how do we get the naming SARS. Well, SARS stands for Severe Acute Respiratory System, and coronavirus is abbreviated COV. So COVID-19 came out of coronavirus disease discovered in 2019. So it's considered a novel virus because there are no prior human diseases involving the virus's exact genetic makeup. What that means is that when a new virus shows up on scene, some pretty smart scientists know how to sequence the genome of the virus. There's a lot of theories about where this virus came from. And you may have heard it came out of a live animal market that was in Wuhan, China. Well, we know through history that novel viruses do come from close contact between animals and humans. Let's go all the way back to smallpox. So smallpox started out as the cowpox virus. It was something that infected cows, and then it made a jump to a milkmaid. And then that milkmaid was able to infect a farmer's family, and that's where smallpox came from. It was a jump from an animal vector to a human vector. And so when we don't know what this virus is and we've never seen it before, it's labeled as novel. It is considered to belong to the coronavirus family. And if you're up on and I think the Latin is corona is crown. So coronavirus means crown virus. And it gets its name from those spike proteins that are around it, because if you look at it, it looks like it's a crown. Well, we already know coronavirus infects lots of people, because it causes a lot of common colds, which are less lethal. But two of the cousins of the COVID-19 virus are SARS and MERS, and we know that those were extremely lethal and deadly, and they did move their way toward becoming a pandemic. So how does COVID-19 infect human cells? So this graphic shows you that you see those blue knobs sticking off the virus in the upper left-hand corner. Those are the spike proteins, and those are going to be the stars of the hour, because we're going to talk a lot about those spike proteins. Those spike proteins bind onto our receptors, a lot of them in our lungs, called an ACE2 receptor. You can think of that spike protein as a key that unlocks a lock to a door, and the door is the doorway to our cell. So the key of the spike protein fits into the lock, which is the ACE2 receptor, and unlocks the door and allows the virus to enter into our cell. When the virus gets into our cell, it releases its genome into the cell, and then it starts replicating itself using the copy machine of our cells called ribosomes, which are those three blue exclamation point looking things. So our ribosomes are, you can think of as kind of the Xerox machines of our cells. We all have them. And in normal times, we use those ribosomes to produce our own proteins, but the virus basically hijacks those ribosomes and starts producing its own protein, which is replicating itself, and then repackages itself and then is released out of the cell. The reason why viruses are bad actors is the fact that they can produce hundreds of millions of copies of themselves in a fairly short period of time. So this process happens extremely quickly, and then we get lots and lots and lots of virus floating around in our bodies. So let's go through a little bit of vaccine history. I want to take you back to 1918 to the flu. So the 1918 flu infected about 1/3 of the world's population, and the mortality rate from the 1918 flu is variable because the medical records weren't nearly as good then as they are today, but it fluctuated between 5 and 20% of those people that got infected. But it was a pandemic. If you look up to if you just go up a little bit and to the right, you see polio, then you see smallpox, two more pandemics that happen. And what you start to see is you start to see this line forming that goes toward the top right part of the screen. I'll come back to that. But go up a little bit to Ebola. You see Ebola. Everyone here on this call probably is familiar with Ebola. Ebola is incredibly deadly. So as you go from the bottom to the top of this screen, you're getting more deadly. And as you go from the left to the right of the screen, you're getting more contagious. So what this means is that Ebola was kind of contagious, but it was extremely deadly. If you're a virus that wants to cause a pandemic, you don't want to kill your host. And that's why Ebola never became a pandemic, is because it killed its host very quickly. So the spread was a lot less. Let's go to the bottom right, measles and cholera. So measles is extremely contagious. However, it's not as deadly as Ebola. So I want to get back to this center line that kind of runs up here. If you are a virus that wants to cause a pandemic, you're going to want to hug this line kind of tightly. You want to have the perfect balance of how contagious you are and how deadly you are, because you don't want to kill too many of your hosts, but you want to be able to spread pretty efficiently. And so if we're looking for this pandemic right now, from what we know today, the coronavirus, the COVID-19 pandemic lives right about there. It's living right within that line pretty perfectly. It's got the right balance of how contagious it is and how deadly it is. So how do we fight it? Well, if you have a bacteria and you have pneumonia, you have the ability to receive an antibiotic. And that antibiotic can then kill the bacteria. However, when it comes to viruses, there are no antibiotics. We have medications that attenuate viruses. In other words, that can slow them down or change our response to them. And a good example of that is HIV. Back in the 80s, HIV was considerably more deadly than it is today. And that's because we have medications, but we're never going to get, likely in today's world, all the way in front of it. So how do you control a virus? The only way to control a virus is through a vaccine. The only way you can get in front of it is a vaccine, because what we ultimately have to do is we have to build immunity. Immunity is the key to getting in front of a pandemic. And maybe some of you have heard of herd immunity. Herd immunity means that we get enough people in society that have immune protection from the virus, so that it can, so that we can adequately defend ourselves against it and slow the spread. So for this pandemic, it's anywhere between 60 and 70% of the global immunity that we need to get to establish herd immunity. So why do we need a vaccine if we have so many people who've contracted coronavirus? Well, I already told you 60 to 70% of the world's population will need immunity in order to stop this particular pandemic, and those stats come out of the CDC. But what we are discovering now, that we have some vaccines that are coming to market, and we have tens of thousands of human volunteers that were able to check their blood and measure their immune response to a vaccine compared to the actual virus. The human immune response to the coronavirus, to this COVID-19, is good and adequate and probably provides protection for about 90 days. However, the immune response to a person that's received the vaccine is ordinance of scales stronger and more aggressively responsive than if you had just had the viral exposure. So comparing two people, one that's had the virus, one that got the vaccine, the person who got the vaccine, their immune system appears to respond much stronger, much faster, squashes the virus sooner, stops the spread more effectively, and also potentially provides a longer duration of immunity. But that length of duration of immunity currently is still the unknown. But 9 months into these vaccine trials, the immune response to the vaccine still seems to be extremely strong. And so now I'd like to introduce you to a concept that I actually just recently learned myself. And I want to introduce you to the idea of generations of vaccines. So in the COVID-19 pandemic, there are currently 9 first generation vaccines going through trials. So a first generation vaccine is our tried and true method of developing vaccines. This is the one that takes quite a while. First generation vaccines use attenuated virus that makes the virus non-infective. So it can't reproduce, it can't do any damage, but it is the actual virus. And our immune system, though, can still develop learn or can educate itself to respond to the presence of the virus using this vaccine. You can think of some examples that we already have of first generation vaccines, like influenza, polio, measles, mumps, rubella, chickenpox, rotavirus. Those use actual vaccine, actual virus, but the virus is attenuated. It's made not able to reproduce. But those take months to develop. If you get the flu vaccine, one of the questions they ask you is, what are you allergic to? Are you allergic to eggs? And the reason for that is because these vaccines are grown in an egg culture, and they take months to years to grow to enough numbers to produce enough vaccine. So it's a very slow process, but it is tried and true. Second generation vaccines, of which there are currently 72 in trials right now for COVID-19. Second generation vaccines have a piece of the virus, the spike protein or some other antigen that's been attached to another virus or another vector that normally wouldn't infect humans. Say, for example, a chimpanzee adenovirus. So chimpanzee adenovirus wouldn't cause any problems in us, but scientists are able to couple that chimpanzee adenovirus with a piece of the COVID-19 virus and then introduce it into us via a vaccine. And then that chimpanzee adenovirus will express that spike protein in this example, and we'll be able to create an immune response. The pattern that you're starting to see unfold in front of you is the fact that we somehow need to educate our immune system. That's what a vaccine is all about. It's about educating our immune system and teaching our immune system what to look for. And finally, third generation vaccines, of which there are 27, currently in development and in trials. These vaccines are the new kids on the block. They're the new generation that have got small segments of the genome encoded in them. And that genome then is able to use our own machinery to reproduce a very small, non-virulent, non-deadly piece of itself to, again, educate our immune system. And this is where the Moderna and the Pfizer vaccines live. They are third generation vaccines. Some of you may have been seeing in the news, AstraZeneca has been released in the UK. AstraZeneca is a second generation vaccine. It uses chimpanzee adenovirus. So let's talk about the two big kids on the block that are around right now. COVID-19 vaccine. The two leaders right now are Pfizer and Moderna. I know that at least I'm a Kaiser doc. I told you about that at least at my shop, I received the Pfizer vaccine and will receive my second booster on Friday. But as recently as yesterday, people who are getting the vaccine because of supply availability are getting Moderna. I want to say up front that these are essentially identical. They are identical. The only difference between them is their storage requirements. So here's a coronavirus family. Across the top are the 4 common cold varieties that we see in coronavirus, but across the bottom are the deadly cousins, MERS, SARS, and COVID-19. So I want to talk about MERS because there's a lot of discussion about how fast these vaccines were developed. And MERS brings some clarity and answer to us. So researchers at Oxford University were developing the vaccine technology that's encoded in the that we currently are using through Moderna and Pfizer, but they're using it for MERS. So I want you to imagine an assembly line. We're going to build a car. We're going to build a Corvette, and we have to build that assembly line in order to construct the car. And you and I are building a car on an assembly line that's going to fight MERS. And MERS has cloth interior. So our assembly line is built to encode cloth interior. Well, in 2018, the Oxford University folks were about done with their trials to develop this vaccine technology, and COVID-19 hit. And when COVID-19 hit, the Oxford engineers realized that all we have to do is just change our assembly plant to be, instead of cloth interior, to be leather interior. So they already had the vehicle to deliver the vaccine, but they just needed to change the interior. And that's the process that was used in labs around the world, is the fact that the process was already developed. It didn't happen over months. It had already been happening for years. They just needed to change the assembly line, and so that the packaging on the inside of the lipid nanoparticle was different. So what's an emergency use authorization? So EUAs are basically sped up processes in the FDA in tightly controlled limited testing in healthy volunteers. If we're not in a pandemic, things happen in series. We have 3 phases to trials. Phase 1 is in a very small scale with limited human volunteers. And in non-pandemic situations, we don't even start in humans. We start in animals or in vitro testing in petri dishes and labs. But it happens in series. We go through phase 1, then phase 2, then phase 3 in a linear fashion, and starting out in animals or in vitro testing before we ever get to humans. And this is why it takes months to years to normally develop a vaccine. However, when a world emergency like a pandemic is declared, the FDA is going to allow these phases to happen first in healthy human volunteers, skipping the animal or in vitro testing. They start small and they assess for safety. And then in phase 2, they expand it to involve a couple thousand folks, checking for safety again, but also testing varying doses. So the Moderna dose is 50 micrograms, but in the phase 2 trials for Moderna, they tested 25 micrograms, 50 micrograms, 100 micrograms, and 250 micrograms, because they wanted to see if varying doses were going to cause varying effects in the healthy human volunteers. And then you get to these phase 3 trials, which we've all heard about and seen talked about on the news. This is tens of thousands of human volunteers. Moderna had about 25,000. Pfizer had about 43,000. So we had put together about 70,000 human volunteers trialing these phase 3 I'm sorry, these third generation vaccines. Here's the other key to why things happened a little faster. I mentioned earlier that in non-pandemic situations, things happen linearly or in series. When you're in a pandemic, the FDA will allow the phases to happen in parallel. So phase one kicks off, and then a short time later, phase two kicks off, and then a short time after that, phase three. So you could theoretically have all three phases happening at once, which is, and also starting off in just healthy human volunteers. That explains why you can speed up this process. So if all I had to do is change my assembly plant, I'd already had the vehicle built, and I was allowed to do the phases in parallel instead of series and start in humans, it starts to become a little bit more clear as to how this all happens so quickly. So I want to talk about the Moderna phase 3 results because from what I am told by the Department of Public Health, the Moderna vaccine will be the one that's offered to the fire service agencies and the private agencies as well. And in the phase 3 Moderna trials, there were 25,600 that were fully vaccinated. And they were careful, as was Pfizer, to try to balance it with folks over the age of 65. So about a third of them were over the age of 65. Almost half of them had medically high risk conditions like HIV or hepatitis or diabetes. And then about a quarter of them were from underrepresented populations because we all saw the news in the summer, the fact that COVID-19 seemed to be impacting the minority population disproportionately. So we wanted to make sure that there was enough of that population in the trial to declare safety. And then durability of immune protection, I kind of hinted to recently. So a New England Journal of Medicine just published an article about mid-December that shows that they're 9 months in, excellent antibody protective ability 90 days after the second injection. So side-by-side comparison of the two, I mentioned they're essentially identical. They're both RNA-based vaccines. They both require 2 injections. The 21 and the 28-day is something that the manufacturer chose in their trials. They can't just change the game plan right in the middle of their trials and say, well, we're going to go to 28 and then 35. They chose 21 and Moderna chose 28, and they need to stick to that to stay in the trial. And then they are both equally effective. 95 and 94 are not different from each other. They're not statistically different when you're talking about 20 to 70,000 people. And the common side effects are nearly identical. I got a little bit of injection site pain, kind of like you'd get with a tetanus shot or a flu shot, and that's about it. Some people that I know have gotten their second injections and they're not reporting any serious side effects. But if you're expecting to get a fever, fatigue, or some muscle aches, you could probably get it after your second injection when your immune system has already gone to school once and knows what it's looking for. All right. So I want to take a little bit of time to go through how the vaccine actually works. I'm a huge Matrix fan, and the key to the vaccine is replication. So back in early 2020, scientists, I already said earlier, sequenced the genome for the virus. And they found and discovered one part of the genome, this little red squiggly line right here, encoded the spike protein. And I don't know if it was a theory, if they knew this already, but it would make sense that our immune system would respond most vigorously to something that it can see on the outside of the virus. So this spike protein was the key target for our immune system to be able to identify what coronavirus looked like. So they took that little sequence out, they isolated it, and then they made millions of copies of it. And they just are making copies of just that part of the genome that sequences the spike protein. And then they package that inside a lipid nanoparticle. That's a key part of this whole process. Our cells have naturally built-in protection to stop things from getting in. I showed you really early in this presentation that coronavirus spikes are like a key, and the ACE receptor is like the lock that lets it into our cells. Under normal circumstances, our cells don't let anything in. So you have to put it in something that can readily cross our cell membranes, and so that you can get this RNA into the cell. And that's this lipid nanoparticle. A lipid nanoparticle freely crosses our cell membranes and allows this RNA to get just inside our cells. And then they put that into a vaccine. This graphic shows how that works. So the lipid nanoparticle approaches the cell and then releases the mRNA spike protein into the cell. And then these two upside down kind of looking rocks, those are the ribosomes. Remember I talked earlier about that's the Xerox machine of our cells. That mRNA from that vaccine then uses our ribosomes to encode proteins that are the spike protein. That's the only thing that's made. I want to take a moment here to point out something that's very important about our own biology. We, you and I, produce mRNA. Our cells produce mRNA, but where does that come from? The mRNA comes from inside the cell nucleus, that circle that's down in the bottom right of that cell. That nucleus only has a one-way street. mRNA can only flow out of the nucleus. It cannot flow into the nucleus. And so maybe you've had friends tell you, or some people are concerned that this mRNA can somehow change the human genome. Well, biologically, that's impossible because the mRNA in the vaccine can't cross into the cell nucleus where our genome is contained. So that process would not be allowed, and it would be stopped just by the way that you and I are built. So we're producing spike proteins using our ribosomes, using our cell Xerox machine, and then those spike proteins start to get expressed on that cell and released from that cell. And that's when the army of our immune system starts to go to school. So this cell on the top right is a macrophage. It's basically the digester of all things in our body, all things foreign. And this thing finds these spike proteins and it digests them. And it says, huh, you don't belong here. I'm going to show you to other people. And so it packages those spike proteins and expresses them on its surface. And then the educators of the immune system show up, these helper T cells. These macrophages are engineered to work with helper T cells. That's how they work. So when the spike protein is shown to this helper T cell, it goes to work and it says, oh, you're the dude who doesn't belong here. Okay, I'm going to remember you, but I'm going to go tell some friends. So that helper T cell goes and seeks out the Army, Navy, Air Force, Marines, and Coast Guard of our immune system, these B cells, which are the ones that launch the attack against anything foreign. So these B cells then are taught by the helper T cell what to look for, and these B cells then start to spit out antibodies. And those antibodies float through yours and my bloodstream, and they go looking for this thing called the spike protein, and they inactivate it and kill it, therefore stopping the spread of the virus through you and I, and killing it, and also stopping us from getting sick and spreading the disease. So that in a nutshell is basically how these vaccines work. I want to take a moment and show you a graphic. This came out December 31st, 2020 or 2020. So, and this is an important graphic. This was in New England Journal of Medicine. This is the Pfizer trial. If you look on the bottom, it says BNT 162b2, 21,669 participants that got the vaccine, got the Pfizer vaccine. And the placebo is a match group of 21,686 people who got basically saline or water. So as you ascend higher in this graph, it's the cumulative incidence of disease. These are the number of people that are getting sick. And so with the next person that gets sick and the next person that gets sick and the next person that gets sick, that number starts to climb higher and higher up the scale. If you notice that there's a divergence right around day 12, look at the inset that's in the top left. Right around day 12, there is a divergence of that red line. Those are the people who got the vaccine. If you remember what I just said a second ago, this is cumulative incidence of disease. So in the people who got the Pfizer vaccine after dose 1, this is 12 days after dose 1, the rate of illness completely changed course and started heading off to the right side of the graph. And fewer and fewer and fewer people of those 21,669 got sick. But I do want to point out something also important in this graph. Even though these people had the vaccine, some of them still got coronavirus. And that's a very important point. This vaccine and all vaccines are never intended to stop you from ever getting sick. That's important to know. Influenza vaccines, the same exact way. What a vaccine's designed to do is to stop you from dying. So what we do know about these vaccines is that a very small number of people after the second dose. So after the second dose of the Pfizer vaccine, 11 of these folks ended up coming down with COVID-19 compared to 180 in the placebo group. So ordinance of scale is smaller. However, this is the big take-home point. In the Pfizer trial, 0 of those 11 got severe disease. I'm sorry, one of the 11 got severe disease, not deadly or hospitalized, just got severe disease, respiratory compromise. But over 50 of the 180 in the placebo group got severe disease. So the take-home point, the vaccine will not stop you from contracting COVID-19 completely, but it will shut down the severity of the disease, which is the major take-home point. All right, I'm going to skip through some myths and facts, not skip through them. I'm going to go through some myths and facts, and then we'll wrap this up, and then we'll take a break and take some questions. So some of the myths and facts, some of the myths I've come across, and then I've tried to find the answers to them with what I think are facts from some reliable sources. So first one, the process of the vaccine development was rushed and haphazard. I spent the first part of this talk going through that. I talked about what an EUA is and how things happen in parallel, and how the assembly plant was already built and we just had to change the interior of what we were building in the assembly plant. So it was fast, but it was not haphazard. COVID treatments have gotten much better, so the vaccine is unnecessary. I've kind of also hinted to this as well, and the fact that people get an immune response, but it's not nearly as vigorous as if you have the vaccine. But here's even more important. I work in an emergency department. I have intubated people with COVID-19 that are 20, 30, 40, 50, every decade of life in the last 9 months. Having worked in emergency services, first as an EMT, then a paramedic, and now as a physician for 16 years with Kaiser South, I have never seen something like this, especially in the emergency department. As you walk through, and I'm going to work a shift this afternoon at 4, as I walk through my emergency department, if I make a right turn as I come in, we have dedicated an entire wing of our emergency department to ventilated patients. That has never happened in the history that I know of my hospital. So this thing is a bad actor, and it takes people down of all ages. But even the best treatments we have, like steroids and remdesivir and things like that I've given, only decrease mortality by at most about 50%. It used to be that if you go onto a ventilator, starting right around in June and May, if you went on a ventilator, you were more than 95% likely to die. Fortunately, some of these treatments have slowed that process down, but it's definitely not as effective as a vaccine, that's for sure. The COVID-19 was made from aborted fetal tissue. That is just, it's not true. For these vaccines, it was used through the lab to identify the mRNA part, and then the Catholic U.S. bishops came out and issued a statement approving the vaccination with these. The COVID vaccine uses live virus. I've also talked about that. That's not true. It uses mRNA. And it encodes for these spike proteins, and it uses a lipid nanoparticle, and so that it can cross our cell membranes and be effective. There are not any other prior RNA vaccines used in humans. This is also not true, and this is something that I learned and had to do my research on. And this is where my smart friends I told you about educated me about this. Gastric cancer in humans uses this technology already, as does a rare debilitating human peripheral nerve disease called Hatter. And at the end of this presentation, there's about 3 pages of references, and you can go to those references. You can find them. They're not neither of them are internet websites. Both of them are published journal articles out of New England Journal of Medicine, I think, is one, and JAMA is the other. RNA vaccines can implant material in the human genome. I already talked about that. mRNA cannot cross into a nucleus. It can only exit a nucleus. The COVID-19 vaccine will stop you from contracting COVID-19. Again, we just covered this. It won't, but it does stop the long-term sequelae. And some of these long-term sequelae we're starting to see. Just over the weekend, I saw a report on the potential that COVID-19 may cause accelerated dementia in older folks. And we already know about cardiovascular effects. Just yesterday, I was on a conference call about athletes. You guys have heard about some of these athletes that contracted COVID-19 that can't even climb a flight of stairs, and these guys are conditioned professionals. So it does cause long-term effects in the lungs. And I also know about it causing vasculitis. It causes something called COVID toes, which is an inflammation of the vessels in the fingertips and toes, which is extremely painful. And it happens and lasts for about 3 weeks, but it causes vasculitis in humans as well. Ill effects from the vaccine won't be seen for months or years. Well, I just got to be honest with you. We don't know enough about this vaccine and it's not out far enough. But what we know so far is that it doesn't cause ill effects, at least in those volunteers that have made it this far in the trial. And these trials continue. They don't get to 90 days and just stop and say, well, we're good. They're going to follow these folks for a couple of years and continue to follow them. And I just learned yesterday that there is a citizen in Elk Grove that is in the phase 3 trial of Moderna. Now, remember, I told you there's only 25,000 people that were in those trials, and one of them lives here, right here in Elk Grove. And then finally, will the vaccine cause you to have a false positive test for COVID? No, the vaccine's designed to create antibodies. It doesn't, our COVID tests that we're using in the fire service look for the actual antigen or the presence of the virus and its genome. It doesn't look for antibodies. So it won't cause a false positive test for COVID. This is where the changes have happened in this talk. I get a lot of questions about pregnancy and lactation, and I'm going to tell you that there are, you're going to find differing information. I want to try to bring clarity to that. So if you're a female that's trying to get pregnant, is pregnant, or is lactating, Pfizer and Moderna are both currently evaluating the safety, but there was only 36 women that inadvertently were pregnant during the Pfizer trials, Moderna trials. None of them have any adverse effects, but you can't base a world opinion on 36 women. And so they are continuing to follow them and evaluate for safety, and then including and expanding their trials to include pregnant and lactating women. So I hope that that answer comes soon. But if you do some searching, you'll find the American College of Obstetrics and Gynecology has a position statement actually encouraging pregnant lactating women to get the vaccine. So this is where you might get the divergence. And the CDC says, well, we don't know enough. It's likely safe. It's a personal decision. And ACOG says, go get it. So to bring clarity to that, here's kind of some of my thoughts. The reason why I think this is safe is because there is no live virus in the vaccine. That's step number one. There's no way to infect either the mom or the fetus. The vehicle for the vaccine is actually destroyed quickly. This lipid nanoparticle is destroyed almost immediately when it releases its mRNA. And the mRNA can't change the human genome. So at the end of the day, if you're a high risk, if you're female with high risk, like asthma, COPD, diabetes, hepatitis, you might consider getting the vaccine. However, just like with all vaccines, and this vaccine is no different, this is a personal choice. Ladies and gentlemen, this is a personal choice. I'm not here to bang on my chest and say, you should get the vaccine. I told you very early on, my role here is to educate you, and I'm trying to do that. Lactation is highly unlikely to infect the infant and is considered safe, but it's a personal decision that you should make with your doctor. So I hope that answers some of your questions. I know many of your wives and some of the women listening to this are either pregnant or thinking about becoming pregnant, or are already have already given birth and are lactating. I hope that this helps you a little bit. So next steps. So for us in the fire service, we're not changing our PPE use anytime in the near future for several reasons. One, it's likely going to take us months, depending upon who you listen to, years, to get enough immunity to this thing in the world, and so that we can safely kind of come off of our masks and start to go back to what we used to know as normal. So nothing's going to change in the near future. Also, because remember, I told you that you can still contract the virus even though you've had 2 doses of the vaccine, which means that you could still transmit the virus even if you've had the vaccine. Hope that makes sense. So Operation Warp Speed, this is just a couple slides about it. If you don't know what that is, you can do some searching yourself, but this is how they distributed the vaccine so quickly. Basically used FedEx and UPS to get it out quickly to those places. 5 sites in California were chosen for Pfizer to receive them, and then they were distributed from there. Here in Sacramento, UC Davis was one of those sites. And finally, this is just some more graphics about the distribution that I wanted to put in there. History repeats itself. This is Elvis getting his vaccine for polio way back in the day. But I want to encourage everybody. if you felt like this was helpful or didn't feel like this was helpful, need more information, my daughter, who's a scribe in an emergency department in Boise, and is also considering going to emergency medicine. She's done a lot of her homework too, and she found this and introduced it to me. And this series called Coronavirus Explained on Netflix is kind of like those National Geographic movies you watch. But they go farther than that. They actually interviewed the dudes in Oxford that developed this technology. They interview the CEO of Johnson and Johnson, who's in charge of the labs that are developing this vaccine, and then the distribution part as well. Extremely informative, breaks it down. I loved every second of it, and I shamelessly grabbed some of their graphics that explains the 1918 flu and all that kind of stuff. So really, really useful. Sit down, take a look at this. They're only about 20 minutes long. I think there's 4 videos, really useful. And then finally, these are my 3 pages of references that I used to find the information that I found. And that's the conclusion of the presentation. All right. Do you want to read them, Chief? And then I'll just kind of answer them.
That's the way that I was gonna run with it, if that's okay.
Perfect. Works out great.
After you've tested positive for COVID, how long do you need to wait before you get the vaccine?
For the Moderna and Pfizer vaccine, the recommendation is you wait 14 days after you've tested positive for COVID. Anecdotally, I think that people who have recently tested positive for COVID may have a more vigorous immune response to the vaccine. So those are the ones we just want to be careful. And actually, I talked to a friend of mine yesterday. This is really good timing, because I told you this information changes every day. Peter Antevi got his second dose and preempted himself. Peter Antevi, for those of you guys who don't know, invented the Hantevi system you guys are using. He's a medical director in Broward County, really good guy. He got his second dose, and he took a Tylenol before he got at the same time he got his second dose. And he said he had very minimal symptoms and problems. So I'm not answering the question very well. Let me go back and answer it. 14 days is how long you have to wait. And you can expect potentially to get just a little bit of a low-grade fever and some more of those muscle and body aches.
There is another question along the same line, and they ask, if you are going to have reactions based on the fact that you've had COVID before, should we not get the vaccine, or is there some pre-treatment like an antihistamine that we should take?
Oh my goodness, I didn't realize I was answering that because I haven't seen that question yet, but yes. This is what I'm going to do on Fridays. I'm going to take a Tylenol as I'm heading in to get my second dose. And I'll probably take a Tylenol the next morning as well. That should be all that you need. You don't need an antihistamine because it's not an allergic like histamine type response that creates the pain and the muscle aches and a little bit of a fever. It's the global immune response, which is nothing that a diphenhydramine or Benadryl would help with. So Tylenol would be the best friend for you.
And I apologize, I misread the first part of the question. They are talking about severe allergies. So the histamine point was related to the severe allergy piece.
Okay. You can. There's no recommendations from the manufacturers, and there's no recommendations from the Department of Public Health nor the CDC that you take an antihistamine before. That would be a personal choice. The only people that cannot get the vaccine are people that have known anaphylactic reactions to components of the vaccine. And when you get the vaccine, you'll be able to see the components in it. Most of it I can't pronounce. It's part of the lipid nanoparticle carrying vehicle. So you can take a Benadryl, but even if you've had prior anaphylactic reactions or allergic responses to things, all that means is that we're going to watch you after you get your vaccine for 30 minutes, just to make sure that there's no severe reactions to the vaccine.
So the next 2 questions are related to people with autoimmune disorders. Has COVID impacted this group of people in any significant way? To start.
I couldn't quote you numbers. I'm sorry. This is one of those ones I'm just going to say, I don't know. I can't say that it's disproportionately choosing or infecting people with autoimmune disorders. So I can't answer that for sure. So I'm going to say, I don't know.
And are there any significant side effects of the vaccine for people with autoimmune disorders?
This one I can answer. I have been involved in our vaccine clinic at Kaiser South. Been talking to our rheumatologists. So rheumatoid arthritis is a common condition, and that's autoimmune. And our immunologists and our virologists and our infectious disease docs are recommending, and I have not seen anything different unless someone else has, that you can get this vaccine even if you have an autoimmune condition.
The next question is, if you have received the vaccine and developed the antibodies and never had the actual virus, does it now qualify us to donate convalescent plasma to those who need?
Oh my gosh, that's a fantastic question. I don't know the answer to that, but it makes intuitive sense. But I'm going to write that down. I actually have never been asked that question. That's a fantastic question. So I'll see if I can get the answer to that, but I don't have it right now. Sorry.
And the second part of the question is, does receiving the vaccine affect your ability to donate whole blood or plasma?
No, it does not. Because this is not a live or attenuated virus vaccine, and there's no live particle in it, it does not stop you from donating blood.
There's been a lot of information about females and pregnancy. This question is related to, should men wait to get vaccinated if they are for unknown sterilization reasons?
No, I don't think that you need to. Again, this is a personal choice. This gets to the personal choice part, okay? As a scientist, as a physician, as the medical director for the fire service, I'm going to tell you my opinion is that there is no way that this affects the germ cell line in just the same way that mRNA does not enter into the cell nucleus. So to affect the germ cell line, you would have to change the human genomic structure. So I don't see that there would be any effect on sterilization, on your ability to reproduce. But I'm going to just also put the caveat in the fact that, you know, again, it's a personal choice and we don't have years and years of information about this. We have years and years of information about the smallpox vaccine and other vaccines that don't seem to affect that. So I'm going to say it's safe, but we don't have 70 years of information on it.
If you have tested positive for COVID-19 and after 14 days of being clear of symptoms, will you test positive again?
No, and I'm thinking that you're talking about the vaccine. Will the vaccine create another positive test? Am I understanding that right, Chief? Is that how you read that question?
That would be my assumption, yes.
Yeah, so no, once the vaccine does not create positive tests because we're not looking for antibodies in our tests. We're looking for the actual presence of the antigen, which is the nucleoside capsule and the structural makeup of the virus itself. So no, it won't trigger a positive test after you've had the vaccine. However, a caveat is if you were infected with COVID-19, generally some people are staying positive with their nasal swabs for as long as 90 days, which is why the Sacramento County Department of Public Health recommends against repeating nasal swabs until 90 days after you have tested positive.
What is in the vaccine that people are having allergic reactions to?
That's another one where I'm going to say I don't know. We have seen 2 out of a couple thousand people at Kaiser South have what we would determine to be an allergic reaction. So that would be hives or some swelling. And I don't know. The components of the vaccine itself are mostly around the lipid nanoparticle, and our immune system only really reacts to proteins. So that's a big unknown. Tons of people are looking into that, but the rate of severe allergic reactions to this vaccine is extraordinarily small, very small, but it's not zero, which is why there's a safety component built into this in the observation time, because everybody, well, not everybody, everyone except one person I know of has had that allergic reaction within 30 minutes. The one person that didn't got a rash and ended up coming back to the ER.
I don't think you covered it in this one, so this is a good question in reference to the new strain of COVID. Is there a strain, and will the vaccine protect you from the new strain or mutated strains of COVID?
Yeah, so this is thank you for asking that, because I did not cover that in this one. So the short answer is yes. The vaccine does appear to be protective against these strains. And you're right, I didn't cover this in this presentation, and I'm glad you brought it up. So there's a lot of alarm about the fact that this virus is mutated, but viruses do that. That's just kind of modus operandi. When you are in the business of presenting millions of copies of yourself, every now and then there is a little change that can happen in the genetic structure during the copying, because there's just a slight mismatch. And some of those variants survive, some of them don't. And so the one that we're seeing, at least in the UK, that was in Colorado and now we believe is in California as well, seems to be more virulent, meaning that it is more infective. So translating with more infective also translates to more people dying, because I don't think necessarily we're seeing a higher death rate, but in sheer numbers of people getting infected, which translates to a higher death rate, that has happened. So how did this happen? So this new strain appears to have just a little bit better key to the lock. The key fits the lock just a little bit better. And the scarier thing about this, and this is all unfolding information, ladies and gentlemen, this stuff changes on a daily basis, which is why I'm trying to keep ahead of it and keep my finger on the pulse. This appears to disproportionately infect people under the age of 20. So don't know why. I don't have any genetic explanation for that, but it seems that younger people are getting more infected. It could be that that younger folks are just kind of done with this thing and they're getting back together in large gatherings and things like that. That's a plausible explanation. But this new variant just seems to have a little bit better key that fits the lock, that opens the door a little bit better. But the vaccines that were created, think of a broccoli, right? And those broccoli have multiple flowerets that come off of it. The new strain has just a little bit different looking floweret off of one side, but the vaccine's effective against the entire broccoli. So even though part of this thing has changed, the rest of the vaccine is still recognizes, knows, and attacks the rest of this spike protein that has not changed. So the vaccine's still effective. The new strain appears to be more virulent, and it seems to be disproportionately infecting younger folks.
Do you know what preservatives are in the vaccine?
I do, and I'm gonna grab them for you. If you just give me a second, I will read them to you. But I'm grabbing them. Hang on a second. Can I? I'll read one that it's come through to me, Rick, if that's okay, Chief.
Absolutely. Go ahead.
We have received questions regarding the possibility of the vaccine targeting the same protein that develops the placenta. That's an I don't know. I have not come across that information. And if you guys come across information that you think can help me, please send it to me. Right. Just this morning, I had a friend of mine who's a captain send me some information and said, hey, have you considered this? So I went out and did some homework, and we're interacting. But this is sharpening iron, right? I'm educating you. Feel free to educate me. If you come across stuff about it attacking a protein on the placenta and you think you have credible information, please send it to me so that I can educate myself and I can ask people, if I don't know the answer, smarter than I am, and that won't be hard to find. But anyway, I'll find the answer for you. Here's the components. This is the Pfizer vaccine. The Pfizer vaccine components do contain polyethylene glycol. So it contains mRNA, lipids, which if you just forgive me, I'm not going to read this, but it's 4-hydroxybutyl azine abyss. I mean, hexane 6,1-bil. I'm not going to read that. Polyethylene glycol, potassium chloride, monobasic potassium phosphate, sodium chloride, bibasic sodium phosphate, dihydrate, and sucrose. So those are the components of the Pfizer vaccine. The components of the Moderna vaccine I don't have right here in front of me, but you can find them. All you need to do is just do a little bit of searching, and you'll be able to put in components of Moderna vaccine, and you'll find the answer.
So next question, are there any concerns with cancer survivors and the vaccine, or any concerns with drug interactions?
No, cancer survivors, no. They are probably a higher risk population and should be one of the individuals that should consider getting the vaccine. Drug interactions, no. Again, lipid nanoparticle, there's no drug in it. And people, I personally have been with people who have anaphylactic reactions to penicillin, to other antibiotics, and we're with them through it. None of them got reactions, at least the people I was with, and that's a couple dozen folks who have pretty bad reactions. Just because, like I said, I worked the vaccine clinic for a couple of days, and so I got a chance to be around those folks. Didn't see any of those reactions at all.
So in the presentation, Doc, you talk about long-term lung and cardiac and potential dementia issues with the virus. If you do not contact the virus, will the long-term health effects be less intensive if you do get the vaccine versus if you got it without the vaccine?
Okay, so great question. So remember, this vaccine is intended to do only one thing, and that is educate your immune system. It creates a mild to moderate immune response, which is a soreness in your arm. And if you get the second dose, some people get like fevers. Well, when you get the second dose, people get like fevers. I never really went into why there are 2 doses instead of 1. So to answer the question, is the purpose of the vaccine is to educate your immune system. It does not cause the widespread inflammation and, more importantly, infection, right? Because that's the key here. The difference between someone who has COVID and someone who had the vaccine in their personal response is a person who has the infection, the actual virus is in their cells. And so our immune system starts to attack and kill our own cells, right? But if the virus is not in our cells, the immune system will not respond to a cell that doesn't have the virus in it. So it won't attack it and kill it. People are dying not because the virus itself is killing them, it's because of the vigor of their own immune response. This virus produces hundreds of millions of copies of itself, infects cells everywhere in the lungs, and then the immune system just goes to town. And even though the immune system may be able to recognize that this is, or may not recognize that this is human tissue, right? That it's attacking, it thinks that it's a foreign material. So it creates this gigantic inflammation response and gigantic immune response if you're infected. The vaccine only teaches the immune system what to look for. So it doesn't cause an attack or an inflammatory response on human tissue. Does that make sense? Did I explain that right?
I believe you.
Yeah, I mean, that's the best way I can explain it. The difference between someone who's been infected. I got a question here as well. Why is getting COVID naturally less effective than a vaccine? So when you naturally get COVID, you get an immune response, but the vaccine is engineered to specifically teach key parts of your immune system to be supercharged against seeing the virus when it does see it. And how do we measure that? Like, how do I know that? Well, you can take pieces of the virus, like the spike protein, and you can embed it into like a paper in a lab. This is how they do it in a lab. And then you wash a person's blood across the top of it, and you stain the person's blood antibodies with a stain that you can see. And you can tell how much of the antibody is bound to those proteins on that paper, meaning that this would be a lab way of determining how vigorous an immune response is. Well, someone who's had the virus will have a certain level of response and a certain vigor response. Someone who's had the vaccine, is considerably stronger response. It's engineered to teach our immune system what to look for in a very real, effective, and efficient way. So I guess that's the best way I can answer that question.
I've heard that some vaccines given to children can cause autism in certain percentage. Is that a possibility with this virus?
I'm going to say no. This is where you're going to get the scientific community that stand on the opposite sides of the aisle and argue with each other. Probably not so much the scientific community, but people in science and people who aren't in science would be probably a better description. The person who asked that question, I'd really like to encourage you to just go do some really heartfelt searching on the true answer to that question. From what I have found, and this is a very politically charged topic, so I'm going to try to dance very carefully here. From what I have found, the theory of vaccines causing autism originated in a lab in the United Kingdom. And that lab author's research was taken to task by other scientists in the United Kingdom. And after a period of time, they were able to prove that this lab scientist who put that theory out there actually falsified his documents, and he got prison time for that because of the alarm that he created in the UK. So that's my take on it. If I'm wrong, educate me. But if you don't know the real answer to that, the answer is out there. But you need to go to reliable sources, not blog posts or anything like that. I really want to send you to like reliable articles out of New England Journal, World Health Organization, CDC, places like that, that have many scientists working at it that are super smart and try to come down with the right answers. So if you find the answer to that, please share it with me. I have emails for all the fire agencies, and my personal email is drmackey@comcast.net. Send it to me. I'd really love to see what your research is.
Will the vaccine be yearly, as with the flu vaccine?
We will probably know that at the end of the spring, beginning of the summer, because by then we'll have had a full year of measuring those titers. What I was describing earlier about washing antibodies across a paper that has the antigen, that's how we measure what's called titers, or the level of antibodies floating in a person's bloodstream. If the titers are high enough, you will not need an annual update. My prediction right now, based upon what we're seeing with the level of titers, is you will not need a booster every year. But that, again, that information is in flux. This stuff is flying out every day.
I've had a couple of the same questions. So if you could repeat, for those people who have contracted COVID, when would they be able to get the vaccine?
You have to wait 14 days in order to get the vaccine past when you tested positive. So 2 weeks.
Since the virus likes ACE2 receptors, can you give any research or any information about effects on patients who already take ACE inhibitor medications?
Boy, wow, thank you. That's actually the first time I've been asked that one, and I'm not kidding. And I've been asked a lot of questions. That is a great point. So early on, we thought that folks who were on ACE inhibitors had a predilection to getting the disease and being more seriously ill. This is one of those things where I'm going to tell you, I don't know. I honestly don't know. I wouldn't be able to assemble a logical answer. If you are on ACE inhibitors, the only thing that has ever been said that I've ever read about or come across is the fact that folks who are on ACE inhibitors, for some reason or another, seem to have a higher predilection to serious disease. But that was really early on in the pandemic, and now that it's so widespread and really doesn't pick or choose who it wants to infect. It's infecting anything that moves. Then I don't think I can give you a good answer to that. So I'm sorry. That was a long way to say, I don't know.
If you're getting other vaccine injections, should there be a time frame between the two different vaccines?
Yes. Yes. There needs to be at least a 2-week window between when you got any kind of other vaccine and this vaccine. So there needs to be a 14-day span. It'd actually be one of the questions when you sign up to get a vaccine. You're going to get a questionnaire, and that will likely be one of the questions. Have you had a vaccine recently?
So a myth or fact question: if you are already tested positive, there is no need for you to wear a mask in public.
Okay, so that would assume two things. That statement would assume two things. One, that you can't get the virus again and can never transmit it again as either a carrier or an infected individual. And it also assumes that your immune response is vigorous enough to actually kill the virus the next time. So two things are assumed in that statement. Both of them are false. We do know that people can get this more than once, twice, and even 3 times. Probably the first case came out of Utah where a young, he's in his 20s, got infected in March, got reinfected in May, and on his reinfection, where'd he end up? He ended up in the intensive care unit, almost died. So he got it twice, and there's one lady in the UK that's gotten it 3 times. So you can be reinfected, which means that you can continue to transmit. So if you get the virus again, so yes, you need to wear your mask. If not for you, it's for the people around you.
Is there any research on side effects for reproduction? And then what are your suggestions for those who are trying to get pregnant, breastfeeding, or are currently pregnant?
Great question. So the current recommendation is current as of January 4th, 2021. Remember that this is constantly moving landscape and new information is coming out weekly. As of today, they are not recommending that a woman that is trying to get pregnant or is pregnant to get the vaccine because we just don't know. We don't have enough information to make a safe statement. And then as far as breastfeeding is concerned, currently the recommendation is to not get it if you're breastfeeding. Just this weekend, I heard that ACOG, which is the American College of Obstetrics and Gynecology, said that, yeah, if you're lactating, and I heard this, I didn't actually read this. So one of my friends had told me that ACOG had come out with a new statement. When a statement is made, my sources for trust, because I actually know a couple of doctors who work there, and is the CDC. So the CDC will make the statement about whether or not it's safe, and currently they have not changed their position to use it in lactating mothers. Even if ACOG says it's okay, I would continue to avoid the vaccine if you are lactating.
To assist with supply, what other companies are close to releasing their version of vaccines? And will they be similar to Moderna and Pfizer?
The next closest ones that I know about are AstraZeneca, but that is not a 3rd generation vaccine. And there seems to be, from what I'm reading, there seems to be more side effects. I am not aware. I couldn't name names of any other companies in the 3rd generation vaccine that are close to releasing yet. So that's another one I'm going to say I don't know if there are any others. This again is easy to find yourself, and stick to websites that are reliable, like the World Health Organization, the CDC, ASPR, NHTSA. Stick to places like that where you can get some pretty good reliable information. Don't go to websites that say because we're trying to kill you.com, stuff like that. So that's a joke, obviously. Stick to reliable websites.
You've explained that the vaccine reduces the chance that you can contract it and the severity. Could you talk about the impact that has of you potentially giving COVID-19 to somebody who is unvaccinated?
Sure. As I mentioned, at least in the Pfizer trials, I know of in Moderna, I'm going to talk about Pfizer because I know their numbers a little bit better because that's the vaccine I got, and it's the one I studied the most before while I was actually making this presentation. About 11 of the 13,000 folks who got both doses of the vaccine became infected again with COVID-19, meaning that even though they'd had both doses, they were still infected and could still transmit it. So even though you've had the vaccine, it's a very small chance. To give you a comparison of numbers, in the same group, they have placebos. So they had 13,000 plus people who got both vaccines, and in Moderna it was like 12,500. And then they have matched volunteers who don't get the vaccine. They just get like sterile water or saline. So, and then they compare them side by side. In the group that didn't get any part of the vaccine, 180 of them became ill with COVID-19 compared to 11 in the vaccinated group. And of those 180, over 50 of them ended up in the ICU. So, and none of those 11 ended up in the ICU. So that's the take home point right there is yes, there's a very small chance you can get the virus and still transmit it if you've had the vaccine, but there's no chance likely you're going to end up in an ICU. There's probably not zero chance because nothing in life is zero. There may be one or two that do, but it's very unlikely.
Can you talk a little bit about the second dose and the availability of that second dose in the appropriate time frame?
Sure. The second dose is a guarantee. And the way that these are worked is these come to the State Department of Public Health, and then they don't come to there. The State Department of Public Health determines doses and lotting, and the locations that are administering the vaccine are tracking numbers and calendars, and they know how many doses they will need to give at either the 21 or 28-day time frame, and have already been allotted those doses. So even if you have already received the vaccine, your second dose is guaranteed to arrive. You're a great example. I told you guys earlier, I got mine on the 18th, and I got a text this morning that says, remember, this Friday, you're going to get your second dose. So the second doses come lock in step with the first dose. It's not like you're going to get the first dose, then we're going to have to go finding the second dose.
Are the side effects going to be similar to other coronavirus vaccines, similar to the flu vaccine?
So the flu vaccine is not a third generation coronavirus vaccine. So but the side effects are what we're seeing. The side effects to the COVID-19 vaccine are very similar to what you see with the influenza vaccine. It's a little bit of soreness at the injection site, maybe a low grade fever, maybe some muscle and body aches, maybe a mild headache, maybe a little bit of nausea. So yes, it's going to be very, very similar, which is the reason why we won't be and we don't want to give these vaccines while you're on shift, is because then we're trying to figure out if you're actually ill or not. And so I think the ops chiefs are going to recommend to get this vaccine as you're going off shift.
Once you have had the vaccine or a positive result, do the antibodies that you've created will then give you a positive test result if you were tested it after?
No, because the nasal swabs that we are doing, this is a great opportunity for me to share a screen again. So, because I'm going to answer this in two ways. So the test that we're doing right now, if everyone remembers, is a nasal swab test, and it's looking for the actual viral genome. If you've had the Binax Now nasal swab test that's been out there, that's a rapid nasal swab test. If you've had that one, that's looking for the nucleoside capsule. So no, this is going to, the only thing this vaccine does is it educates your immune system. It teaches your B cells how to make antibodies. And those antibodies are the key to fighting the virus. So you won't test positive, but I do want to show you something. If I can, I'm going to try to share my screen again, Rick. Okay, so this is really important. This is a Pfizer graphic that came out in New England Journal, but you can also make this for the Moderna vaccine, basically, because I told you they're identical. This blue line that's traveling from the bottom left to the upper right part of the screen are the placebo groups. And as you go up the right side of the left side of the screen, this is a cumulative incidence of disease. So the next person that gets it, the next person that gets it, the next person that gets it, it's a higher and higher and higher and higher incidence. So the line should go from the bottom left to the top right. That's the placebo group. Look at this red line that kind of breaks off and starts heading to the right side of the screen. This are the people who are vaccinated. These are the people who got the Pfizer vaccine. And I'm going to answer this question that was asked so that I can show you in this corner down here. So a lot of you who are on the phone know and have heard of Hantevi, right? And many of you know that the guy who developed that is Peter Hantevi. Peter and I worked together in residency. He was actually my attending at Pittsburgh Children's. And Peter developed the Hantevi system while we were there. Well, Peter's a very savvy scientific guy, as you can all imagine. And Peter has the ability of measuring his antibodies. So this gets back to the question, will you test positive? So on a nasal swab, no. But I want to answer the question about antibodies, because that's the key here, right? We're educating our immune system about how to produce antibodies. So Peter got his vaccine about the same time that I did and started doing daily blood tests looking for antibodies to the coronavirus. And this graphic will show us that after the first dose, this days after first dose is this bottom line going from the left to the right. You see it goes all the way out to 119 days. Right about day 12, you can look at this inbox up here, this graphic on the inbox sheet. Right about day 12 is where the line departs and heads to the right. This is where the cumulative incidence of disease basically came to a grinding halt, where it stopped to 0. And Peter measured his blood on day 0, day 1, day 2, day 3, day 4, all the way out. And he was on a conference call with me last week and showed me his antibody result on day 14. He was negative for detectable antibodies to coronavirus on day 13, and on day 14, bam, there was a brilliant line that showed that he is now producing antibodies against the coronavirus. So this graphic completely backs up what Peter showed me and what he has done. And this is why another major reason to get the vaccine is you can see those people who got the vaccine, the cumulative incidence of disease basically came to a grinding halt. And you look on the very bottom of that screen, this isn't small numbers, folks. This is 21,669 people who got the vaccine and 21,686 people who did not, who got placebo. 43,000 people compared head to head. And you can see when the antibodies finally show up. So if this is probably the most convincing graph I have probably ever come across. And the reason why to get the vaccine is protection is offered even after dose 1 at day 12. But the reason why we're going to get dose number 2 is because we want to cement into our immune system's memory what this thing looks like. Make it long-term memory. Because I've already had a question, I'll answer it right here if it's okay, Chief Clark, about if this will become a booster or not. And the answer to that is we don't know. We don't know because we don't have enough track record with it about how long the immune response happens. The reason why we get an influenza shot every year is 2 reasons. One, I've already alluded to, and that is that viruses mutate on a regular basis, and which changes our immune's response to it. And the second reason why is because our immune system is not as strong when it changes. So we have to change the formulation of the vaccine and get another vaccine. So I don't know the answer to that or whether or not it's going to be a booster. We expect to know it by next summer.
So a little bit of general information for everybody. There's been a couple questions about Dr. Mackey's presentation. My email is Rick Clark, and that's Clark with an E, C-L-A-R-K-E, at csvfire.com. If you send me a request for Dr. Mackey's presentation, I'll make sure that that gets out to you directly. The recording of this presentation, as well as the presentation on Wednesday, I hope to have to my technical group who does video editing, so they can kind of take out all of the idle conversation and condense it down, but include both question and answer periods as well as a presentation. And I hope to have that out by Friday, if not the first of the week. So those will go out directly to the EMS chiefs of all of the agencies. And again, if you want this presentation directly, then you can go ahead and email me if you're not one of the folks in the fire agencies. In relation to that, there should be from Troy Bear, my ops chief here at Casumas, there should be some sort of announcement at the latter part of today or early part of tomorrow about what the scheduling through public health is going to be for vaccinations of the fire service. So pay attention to your emails that should be coming shortly from them. I want to take a second just to thank my fire chief, Chief Rodriguez, as well as Chief Bear, for allowing us to have this on. Again, always thank Dr. Mackey for his knowledge and experience and time to spend with us to answer these questions. If there are any other further questions that come up, don't hesitate to send them to me, and I'll get Dr. Mackey to answer those as needed. Thanks everybody for their time today. Dr. Mackey, do you have anything to close?
No, I'd like to also thank Chief Rodriguez, Chief Bear, you, Chief Clark, the EMS Division, and CSD for having this. This is huge. It's really important. There will be, and if I get the information on this, on Friday at 11 o'clock, CPF is hosting a similar webinar. I will be on that along with Dr. Galley, who's the HHS Director for the state of California, and Dr. Clayton Kazan, who's the Medical Director of LA County Fire. And we're going to do another one of these for the fire service, but we're going to try to hit the entire state. So if I get that link, I'll send it around the EMS officers to share with you. And thank you again for joining. It's very important. I appreciate it.
All right, everybody, that's the conclusion. Thanks very much for your time. Have a good